kindly request the chairperson to introduce the speaker.
Good afternoon. It's my pleasure to introduce Dr. Radhika. I've known her for so long. She initially started with us as a nepropathologist. And I see that she's achieved so many accolades after that. And please go ahead and present. Thank you.
Thank you, madam, for those kind words. A very good afternoon to all. Yeah, starting with the case, we received a case of 19-year-old female presented with easy fatigue, loss of appetite, nausea, and right 7 nerve lower motor neuron palsy. Serum creatinine was raised. It was 3.4 milligrams per deciliter. Patient was normotensive. On protein was 1+. Pus cells were 8 to 10 per high power field. Patient had previous history of fever 1.5 months back. Serum creatinine was 2.9 milligrams per deciliter that time. On USG, there were both bilaterally bulky kidneys, and renal biopsy was done for unexplained renal failure. So we received these 2 cores of renal biopsy. This is the cortex and this is medulla, and this ball-like structure is a glomerulus which is apparently looking normal, but still there are these round ball-like structures. They are seen throughout the cortex and also one in the medulla. These 2 ball-like structures are seen in the medulla and in the cortex also. So this was giving an appearance of cellular crescents on low power, but when we saw on 20x, this is PA stain, these were actually the granuloma, non-caseating, well-formed, sharply defined granuloma on PS and silver stain. So there were these epithelioid histiocytes and giving the appearance of a cellular crescent, but there is no Bowman capsule, not any capillary tuft, and these were the non-caseating granuloma. There were these multinucleated giant cell, and we can see here the portion of a glomerulus which is absolutely looking normal with no evidence of increase in cellularity. There is no basement membrane thickening, segmental lesions like segment of sclerosis or necrosis or crescents. So this was basically interstitial disease showing lot of granulomas, and those granulomas were showing this intracellular calcification. Those were Schaumann bodies. These purple color, blue colored calcifications which were non-refractile on polarization. On immunofluorescence, there were no significant immune deposits. IF was negative. So the diagnosis was given as kidney needle biopsy show features of non-caseating granulomatous interstitial nephritis, most probably sarcoidosis, and we advised to do serum ACE levels and radiological investigation of CT scan chest to confirm the same. But patient was lost to follow-up, but I later received the information that patient improved on receiving the steroids. That's it. So granulomatous interstitial nephritis we see in drugs, antibiotics like ampicillin, cotrimoxazole, vancomycin, cefuroxime, allopurinol, NSAIDs, diuretics or anticonvulsants. In infections like Mycobacterium tuberculosis, adenovirus, HIV infection, fungus like Histoplasma, Candidiasis, Cryptococcosis, and inflammatory or systemic conditions like sarcoidosis, Wegener's granulomatosis, Tino syndrome, Crohn's disease, or any hematological malignancy like leukemia and multiple myeloma. So I thought these pictures were be useful for the students, so I put up this case. Now coming to the next case, or should we go ahead? Okay. So the next case we received is 3.5 months old female baby with failure to thrive, born to non-consanguineous parents with no significant family history of renal disease, Serum creatinine was 5 milligrams per deciliter. Proteinuria was subnephrotic. For that age, I think it is nephrotic, 2 grams per 24 hours. On the urine examination, there was active urine sediment, RBCs 8 to 10 per high power field, WBCs 4 to 6 per high power field. Patient was anemic. On USG findings, CMD was lost in both the kidneys. So we received this core of renal cortex showing these tubules, and these were the glomeruli. Many glomeruli were of infantile type. This is the infantile type glomerulus projecting this. These are the podocytes, and very few occasional normal glomeruli were seen, which was appearing normal. There is some proteinaceous fluid here, but there is no increase in cellularity, no evidence of basement membrane thickening or duplication, or any segmental lesion like sclerosis or necrosis, and no crescents. So something was happening in the tubules. So on polarization, these tubules were refractile. There were crystals. They were refractile in those tubules. Because if we see normally, we are not able to see these crystals, but under polarization, these were fine spicules or plate-like structures, and they were almost throughout the biopsy, and confirming them as calcium oxalate crystals. So they were like this fan-shaped or spicules in the tubules. So when we did on immunofluorescence was negative, but we stained that IF core with HND to see whether that will also show us the crystals. So yes, that also showed. This is under the light microscopy HND stain section, but when we did used polarizer, then it was showing these highly refractile crystals. Immunofluorescence was negative. So it was given as kidney needle biopsy show features of oxalate nephropathy. In view of age of the patient, the advice workup to rule out a possibility of primary hyperoxaluria. So calcium oxalate nephropathy, this patient was also lost to follow-up, but for pictures I put this case. So calcium oxalate nephropathy, it is of two types: primary hyperoxaluria, which is generally hereditary; secondary hyperoxaluria, which could be dietary, like excess use of star fruit, spinach, or nuts; toxic ingestion by ethylene glycol; drugs like vitamin C overdose; and fat malabsorption due to short bowel syndrome; orlistat usage for obesity; gastric bypass surgeries. Thank you.
Thank you, Dr. Radhika. Very interesting cases and very clear pictures of typical cases. Over to Dr. Anuradha.
Excellent presentation, madam. I just have one question. We know that oxalosis is quite common in children. I mean, is quite common and is one of the common cause of CKD in children. So sometimes they present with extrarenal manifestations like deposits in the vessels. So in those cases, can we have a diagnosis from the skin biopsies or vessel biopsies, ma'am?
Yes, I think we can have, ma'am. But those I have not seen.
Did you ever come across?
No.
Nice presentation, ma'am, and
Thank
good
you.
to see you. I always saw in the paper you are.
So any questions from the floor? If there are no questions, we'll end the session and we'll move to the next session.
Thank you. Thank you.
Thank you, madam. Thank you, chairpersons. I request the chairperson and Radhika madam to move to the rear stage for photo.
Let's proceed with the next case presentation. I request Dr. Shabana Madam, Assistant Professor, Usmania General Hospital, to chair. Associate Professor, Usmania General Hospital, to chair the session. I request Dr. Najma Madam, Consultant at Deccan Hospital, to chair the session. I request Dr. Nagasarika ma'am, speaker onto the dais.
Good evening all. It's my pleasure to introduce Dr. Nagasarika. She is an consultant at Yashoda Hospital, Secunderabad, and she has many publications and achievements. Ma'am, you can start.
Yeah, thank you. Good evening all. So this case, at the outset, I would like to thank my teacher, Dr. Swanalata madam, and my dear friend Jaya for organizing this session, and thanks to ISN also for giving us this chance. So I would start with my case. So the histopathological finding of this case is not so uncommon, but the age of presentation and the clinical evolution of the case has made this little interesting and a learning one. So a 15-year-old child went to her local hospital with a history of cold, cough, fever, ear pain. It was diagnosed as upper respiratory tract infection and she was given empirical treatment. However, there was no improvement, so she revisited the same hospital. The routine investigation, CBP, CRP were repeated. Then, yet there was no improvement, and in the investigations it was found that CRP was quite high, and hence the patient was admitted. As part of the routine investigations, urine examination was done, and it didn't show any significant findings except for a few pus cells. So CRP raised further to 99, and there was anemia with elevated WBC count. Chest X-ray was done, and it shows haziness in the upper lobe. CT scan shows consolidation with cavity. So because it's a cavitary lesion in a 15-year-old child, it was suspected to be bacterial of bacterial origin. And the fungal etiology was considered unlikely because there was no any history of immunosuppression. So what is that we are seeing is the patient WBC count is slightly elevated with anemia, and urine examination was normal. Liver function tests were also normal. Further investigations, sputum analysis and bowel fluid did not reveal any particular infective organism. Procalcitonin was slightly raised. However, she was started on, because it's a cavitary lesion, she was started on empirical ATT, and the sample, bowel sample was sent for galactomannan test, and antifungal voriconazole was also started. Then gradually, now the liver enzymes and bilirubin started increasing. Because there was no significant improvement, she came to our hospital in the 3rd week of illness with a history of lower respiratory tract infection with a cavitary lesion in lung. So then the other investigation started, ultrasound abdomen. Now here the kidneys showed abnormal increased cortical echo texture. Corticomedullary differentiation was lost. And now the liver enzymes, which were previously normal, have increased significantly with increased bilirubin and enzymes, albumin low. So because she was started on antifungal treatment, it was suspected probably the raised liver enzymes is due to the antifungal drug use, that is voriconazole, and the drug was stopped. Autoimmune tests were also done, which were negative. And now when the urine examination was repeated, there is significant proteinuria along with plenty of RBCs. So at this point of time, any clinical differentials? If this is the history that is provided to us with the biopsy, being a child with a history of infection, I would have thought of infection-related GN with crescents, because there is significant proteinuria with plenty of RBCs and history of lung infection, evidence of lung infection. So the drug was stopped, voriconazole, because the liver injury was suspected to be due to antifungal. However, the bilirubin remained to be high, and the enzymes, liver enzymes have reduced, but not completely. So the fever and cough has subsided, but the patient complained intermittent abdominal pain with persistent hyperbilirubinemia and erased decreasing transaminase, but not complete resolution. And now creatinine has also increased, has started to increase. So now, because of multi-organ involvement, even after stoppage of the drug, the liver enzymes, though they have reduced completely, still the bilirubin remained high. Because of multi-organ involvement of the lung, liver, and kidney, clinically vasculitis was suspected, was considered, and 24 hours urine protein along with complements and ANCA was sent, and C ANCA has come positive, raised. So definitely, though C ANCA is raised, there will be differential of IRGN because she is a child with evidence of lung infection. Renal biopsy was planned. At the same time, steroids were also started. She improved. So I will just describe the histological findings. We have received a single core. These are the two different portions of the core that we have received. As seen in the urine examination, there are plenty of RBCs in urine, and here you see a busy tubulointerstitial compartment. Tubules are dilated with the RBCs cast, and the interstitium is also widened with inflammatory cells. Here you can see glomerulus. We'll have a closer look at the glomerulus. Yeah. So the same picture of busy tubular interstitium with RBC cast in the tubules. And this is the closer view of the glomeruli. So this is a glomerulus where the capillary lumina are obliterated, and you can see some smudgy material in the tuft. And on the other pic, you can see the tuft luminous, the Bowman space is completely compromised by some spindle cell cellularity. So far you have seen many crescents. Yes, this is the portion of the crescent that we are seeing in the pic. Here you see a beautiful crescent which is occluding the Bowman space. And here again in PA stain we see smudgy material which is partly destroying the tuft and with cellular crescents occupying the Bowman space. Again the crescent with the neutrophils in between. Now this is Messon's trichrome. And here this is the closer view of the tuft, which shows fuxinophilic material with ragged edges, that is fibrinoid necrosis. Again in the Messon's usually highlights the RBCs or anything plasma products. They are highlighted with Messon's as fuxinophilic. You see RBC cast in the tubules. And these are the lining cells. It's a cytoplasm which is staining red, and that is overlying the blue nucleus. Hence you're seeing the red color of the cells lining the tubules. And these are the RBC cast. Silver stain, this will enable us to appreciate the destroyed tuft. Here if you see the tuft is fragmented, here we see portion of the tuft, and here again a tiny portion of the tuft. That shows the tuft is destroyed with the crescents, active crescents. And if you have seen in all these pics, they are cellular crescents. There's no scarring. If there is scarring, it would be pale pink on PAs, and on Messon's it will be dark blue. So all are cellular crescents. The tubular interstitium was very busy, but there was no atrophy. And now this is the immunofluorescence. If you closely look at the tufts, they are actually negative. Whatever you're seeing blobs of material, they are just non-specific immunofluorescent spots. But actually the tuft is negative for IgG, A, M, C3c, C1q, kappa, lambda. So it is pauci-immune. So histopathological finding is pauci-immune, necrotizing, crescentic glomerulonephritis, as was expected clinically. So once we diagnose give the impression of crescentic glomerulonephritis. The next thing is prognostication, prognostic factors with respect to biopsy. So in the biopsy, in 2010, burden classification was introduced to assess the crescents. And the prognostication was done based on the cellularity of the crescents. If they are focal crescents, cellular, then it is focal class. If they are cellular crescents, more than 50% crescentic class. Then if it is a mixed sclerosed and cellular crescents, it is a mixed class, and completely sclerotic, more than 50% globally sclerotic is sclerotic class. So this will help us in prognostication regarding the progression of the renal function. Then it was realized that it is not just a histological finding of the glomeruli, but also the other compartment, that is tubulointerstitial compartment chronicity, and GFR would also enable to prognosticate, to stratify the patient. So hence this ANCA renal risk score was introduced in 2018. There's another score, Mayo Clinic Chronicity Score. This is not specifically for crescentic GN, but for any kind of glomerulopathy or any renal disease. The score is based on the chronicity seen in the glomerular compartment, tubulointerstitial compartment, and the vessels. So this is again useful to stratify, for the stratification of any kind of biopsy. So this is just a burden village. It's a small town of village. Like analogy to the burden classification, this looks like a mixed class. You see partly greenery and partly dried up lands. Okay. So C-ANCA has come positive. Even before the biopsy, C-ANCA has come positive, low complements, and this is positive immune necrotizing GN. And the final diagnosis finally given was C-ANCA associated vasculitis, that is positive immune GN on biopsy. And the liver injury could be partly due to ANCA vasculitis or could be related to drug. And you can see the improvement in the chest X-ray also. The haziness is lost. The question is, was it ANCA associated since the beginning? Possibly. But if you see the pathogenesis of ANCA associated vasculitis, infection is always a trigger. Infection can be a trigger. So in this case, probably started with infection, and that has triggered her, possibly because she has a genetic background which is associated with ANCA vasculitis. So the clinical vasculitis cases, that is GPA, granulomatous polyangiitis, and microscopic polyangiitis, are associated with HLA polymorphisms. And there are genetic mutations also associated with serological ANCA values. So the genetic associations, they say they are more strongly associated with type of ANCA than the clinical vasculitis. And so this case, it was good to know that not only as a granulomatous lesion with cavity it can present, it can also present as a UIP or NSIP or organizing pneumonia, or as a bronchial stenosis, or like a small airway involvement which is described as stream burn. So there are variable presentations of ANCA vasculitis in the lung. So in our case it was like granuloma with cavity. Now the poor predictors are the older age and male gender. So in this case she is young, female, so and all the crescents were cellular. That way she has a better prognosis, but however it is a GPA kind of presentation, granulomatous polyangiitis with C-ANCA, which carries bad prognosis, low complements, and proteinuria. So, and with every relapse there will be decline in renal function, so time will only tell whether how well she will progress. For now she has improved with the corticosteroid treatment, and she is doing well. Just in the making of this crescentic GN, I came across this croissant, the French pastry, which is actually called croissant because of the name is derived from the crescent, as it is a crescent-shaped pastry. It was good to know, so I thought to share with you. Thank you.